shall start with the questions and answers part of the sessions, and I would like you to invite to ask any question to the two presentations we have had. I guess there's a mic if we need it. No questions from the audience? No, really? I have something for them, and I will start with Dominique. I would like her to get a little bit deeper into the governance issue of the cancer programs she's presented. It's been quite interesting for me reading your abstract yesterday that you use the term of the professional bureaucracy when describing the professional
al describir la
issue of the problem, and remember.
Bueno, describiendo con la presentación de ayer por la tarde.
I would like you to describe a little bit more about the let's say the crash, shall we say that has been between the prescribed network and the professionals, and if that has been a real, let's say, conflict or problem, how should we overcome it?
Mm-hmm. Okay, so thank you so much for your question. First, we know that governance in health services always lag behind other issues like coordination at the grassroots level. So I think there's no very much information regarding governance issue. First. Second, we look at the definition of governance that is with a lead organization, and how this lead organization could achieve the function of governance. Governance is the coordination of the whole cancer system. So looking at the values, the distribution of resources, management of relations, and so on. So we saw that this way of looking at governance don't fit very well the professional at the grassroots level, and it's looked like something that is very top-down. So, and there is a discrepancy between what is prescribed at the policy level and what could happen at the professional and clinical level, especially looking at the coordination of care and coordination of communication between professional and milieux of care where the cancer patient and their family goes. So it's appeared that the solution could be to rely on other conceptualization of governance and looking at the dynamics of collaboration and how inside of looking at the function, looking at the process of engagement and how to build collective action into the cancer system. So we continue to monitor what could happen with a change in the way we see governance, and we work closely with the Ministry of Health to suggest a way to have more collaborative dynamics into the governance in itself. So I don't know if I answer your question.
Thank you. Thank you, Dominique. Sorry, there's a mic over there.
Hi. Thank you for your presentation. Related to your question, I was thinking, could it be that there's a certain point where the integration of care goes above what I would say the human level, that it goes beyond what people seem how you say that, that people could work within a certain structure, and when it's too high up, when it's too broad, when it's getting too much prescribed, that at a certain point it loses some kind of human touch in which we don't function at all anymore.
Yeah.
So it would be better to always start from smaller or in smaller groups. I don't know how I should interpret these results like in a practical way.
Yeah. You're very right in describe it at the multi-level of the cancer system, and it's very well known that something that is prescribed at the policy level not always percolate to the grassroots level and reach the patient. The more important point is to reach the patient and the family, and it goes through the professional practices. So you're right saying that the ministry level or the policy level work more on structure, rules, and something like that, prescribing the way the cancer program should be organized. So we have quite good perception of a functional and normative integration. So it's at the macro level, it works quite well, but what will make change into the care, it's the micro practice, and we see that it does not go down. And maybe the solution is not to just govern from the clinical and professional perspective, because they are working hard and fast and so on, and don't have time to always review the function and so on. But there's something to do with the coordination, and it's the main point, and to look at the way it's not just something that should go down, and not just bottom up neither, but to find some point of connection between those two movements.
All right, thank you both. I've got a question to ask to Catriona. Well, two questions indeed. I would like you to tell us a little bit more about the profile or background of the rehab coordinators, and in your slide about the several stakeholders that take part in the process. I would like you as well to tell us a little bit more about the role of families and patients. You mentioned the increasing expectations of the families and patients. I would like you to get a little bit deeper into that.
Okay. So if I start with the first question around the background of the role. So as I explained, it's a relatively new role within the National Rehabilitation Hospital, and it came about really from, I suppose, an observed need within the service to coordinate access to rehabilitation, but also very much in line with standards. So our hospital is accredited with CARF. It's a rehabilitation accreditation system. So it is one of the CARF standards. We also, the role is in line with our national Better Safer Healthcare standard, and also our national waiting list management policy. So everything was, I suppose, supporting the idea of a pre-admission coordinator role. In terms of the interaction with patients and families, so I suppose one of our biggest challenges is that we're a national centre that are dealing with referrals from across the country, and in Ireland, to this point, we don't have well-established primary care specialist rehabilitation teams, and it's a huge gap in the Irish service. So in the presence of the absence, I suppose, of those specialist services at more of a local community level, there's a lot of pressure is placed on this one territory centre. So patients and families become aware very, very quickly of the National Rehab Hospital, and because I suppose from a local context, Ireland is a relatively small country, so a lot of people know of people who have attended the hospital and who have done very well. So balancing this against the fact that there's this, I suppose, imbalanced demand, so our number of beds will never meet the need for services. So it's almost impossible to avoid there being a waiting list. And because we have to balance the level of complexity of the patient with our available staffing, patients with the most complex needs, the most complex disability, typically would wait the longest period of time for admission to rehab. And you can imagine that these are probably the most distressed families because they've had the most catastrophic brain injury or stroke, and yet they're waiting the longest period of time. Often these patients are in acute hospital settings with teams who may have very little experience with a severe brain injury. So teams are not skilled at delivering a service to patients while they wait for us. I think a consequence of that is that teams are not particularly good always at communicating with families in terms of providing information for them. So all of these factors increases the family's anxiety while they have this prolonged wait for admission to us. So one part of my role is linking in with these families while they wait for us. And a lot of that can be done over the phone in terms of providing a lot of support and a lot of education for patients. We do also have one very valuable service within this pre-admission service, and we have a specialist brain injury liaison coordinator who's present today, Rachel. So Rachel provides an outreach service to the most complex patients waiting on the list. So Rachel will go and visit these patients in whichever setting they're in, very often the acute setting, and spend time providing a face-to-face assessment with the patient and providing training and education for the team caring for that patient, and as importantly, we'll spend time with the family. And we do feel that it is a very important service in terms of managing the patient's and the family's distress while they wait for admission. But another key benefit to that service is that it minimises some of the secondary complications that will typically occur with this patient population while they're waiting for admission to specialist services.
Great, thank you. All right, is there any other question or comment from the audience? No? All right, so we are coming to the end of the session. It's a pity that the other two presenters couldn't attend the session. Anyway, I would like to thank the presenters, thank the translators as well. Of course, thank you for coming at this early hour. And now we will have some time to have a coffee and go to the next session. And well, enjoy the rest of the day.